Let's study CSF, CBF, and blood-brain barrier. So these three topics, not so big topics. Let's try to understand them. So CSF is called cerebrospinal fluid. It means it's a fluid that is inside your, not inside your brain. It's like a fluid that takes care of your brain, right? What are the principle? What does it do? Let's see. Production. Well, it is produced by something called as ependymal cells, and these ependymal cells are present at choroid plexus, right? And these choroid plexus are actually present close to lateral ventricle, okay? So this is very important, right? They produce in choroid plexus, and choroid plexus is present at lateral ventricle, right? Why is it lateral? Because this is present like this, right? And then the third ventricle is right here, and then flow is like this, okay? So produced at choroid plexus. Let's see what are the parameters. What is it, what does it do? Let's see. Volume, how much it's present. Well, the volume at a time which is present in your body is 150 milliliter. The rate of production is 550 milliliter per day. So per day you're making 550 liters, and at a time means at one instance you will have 150 ml. So it means that you have a very good excretory system of CSF, right? So the turnover, what is the turnover? It means how many times it's changing itself. Well, if it's changing a lot, it means that it's carrying something really vital. What is it? So turnover, it turns over about 3.7 times, or maybe it turns about 4 times a day. What about the pressure? The pressure CSF creates is about 112 millimeter of water, right? The normal range is about 70 to 180 millimeters of water. Again, this is the range, and normal value is 112. The average is filtration equals to absorption. What does it mean? It means the more is filtered, the more is absorbed, right? It's like the ratio of filtration equals to the ratio of absorption. Okay, so that's the concept here. Okay, so we make about 550 ml per day. Volume is 150 ml. Range is about 70 to 180. Normal value is 112. Okay, why it's measured in H2O, not in Hg? Because Hg, that is mercury, is 13.6 times denser than water. For example, 10 mm of Hg equals to 136 mm of water. So that's why we use water in our body to measure pressure, because it's more micro managed, right? We can manage the number more easily, right? So that's why we use water, because Hg is a bigger unit, because Hg is 13.6 times denser than water, right? So that's why. Okay, let's see the regulation. So I told you that filtration, it means the production, is equals to absorption, right? So the more you make, the more you absorb. It's not like this, the more. It's like, for example, I'm producing like 10 ml. So 10 ml should be absorbed, should be excreted by your system. So that's the concept of this, okay? If there is problem in the absorption, the pressure of CSF will increase, of course. Okay, so what's the regulation? At the level of absorption, the regulation, okay. Circulation, let's see the circulation. Well, it starts at lateral ventricle. So lateral ventricle is like this, I told you. Then after lateral ventricle, it goes to third ventricle, which is in the middle, right there, right? Third ventricle. Then from third ventricle, it goes to fourth ventricle, okay? And then from fourth ventricle, it goes to subarachnoid space. Then it goes to arachnoid. From arachnoid, it goes to venous sinus. That is the drainage of your whole CSF. Okay, let's try to understand this little better. Okay, so what happens is that these cells, these ependymal cells, are present at these lateral ventricles. Okay, and why have we named them third ventricle? It's a great question. The answer of this question is that lateral ventricles are present on the lateral sides, right? Here and here, right? So first we name them ventricle number 1 and ventricle number 2. And then we saw another ventricle. What is ventricle? Ventricle is just a space where CSF flows. So this is lateral ventricle number 1, lateral ventricle number 2. Then we have third ventricle, right? That's why we called it third ventricle. And then we have something called as fourth ventricle right here, fourth ventricle, okay? Then it goes to subarachnoid, then it goes to arachnoid, right? So between these ventricle, we have a lot of ducts, okay? So for example, we have something called as from lateral ventricle to the third ventricle, we have foramen of Monro, right? Then from third ventricle to the fourth ventricle, we have aqueduct of Sylvius. Then from fourth to subarachnoid, we have something called as two foramina. So two foramina, why do we need them? Well, these foramina are actually exit points for this CSF, okay? So from aqueduct of Sylvius, the CSF goes to fourth ventricle, okay? And from fourth, it goes to subarachnoid. Now, between subarachnoid and fourth, we have two foramen, Luschka and Magendie. So Luschka drains the CSF to subarachnoid, okay? And then from subarachnoid goes to cerebral pontine, and the Magendie, it causes the drainage of magna. So what is cistern, by the way? Cistern magna, right? So cistern is like a tank. That's it. So it's like a tank which carries some CSF. Okay. So this is very important. So foramen is Monro between 1 to 3rd. From 3rd to 4th, we have aqueduct of Sylvius. From 4th to subarachnoid space, we have Luschka and Magendie. Okay. So Magendie is a posterior flow of CSF, and Luschka are both laterally. Okay, just like presence of lateral ventricle. Okay, so I hope you understand this point, very important. So from subarachnoid it's arachnoid, and from arachnoids it's venous sinus, and then it's just drainage of CSF. So if we have any obstruction at any point of this tract, right, then we will have something called as increased CSF pressure, right? Not increased intracranial pressure, ICP. Okay, one of the thing is that when we wake up in the morning and when we have headache, it is usually a sign of increased intracranial pressure. Okay, so if you guys wake up with an increased ICP, it means you guys have something called as increased this headache, right? So wake up with headache is a sign of increased ICP. Okay, let's try to let's try to compare CSF and plasma. So what is high in CSF? Chlorine, Cl minus, Mg minus, and not minus, it's just a charge, magnesium. So chlorine and magnesium are higher in CSF. I'll tell you why are they higher. It's very good logical explanation to everything. What is equal to CSF? What does CSF has that plasma also has? Something called as osmolarity. That is around 300 or 270. Okay, so number of particles. Okay, the pressure gradient, it's like same, almost same. It's not same. Other thing that plasma and CSF has in common is that bicarb. The normal level is 22 to 29 milliequal per liter. That's the unit. So bicarb is same as well. What plasma has, right? So higher in CSF, again, chlorine and magnesium. What CSF has which is lower? I mean, what's the lower things that CSF has? One is glucose. So you don't want glucose in your CSF. If there is presence of glucose, it means some bacteria has colonized the CSF, and bacteria needs glucose, right? Proteins, it means something is leaking inside your CSF, right? Proteins are getting leaked because proteins are big bonds, big structure. They should not be inside these Magendie, inside this Luschka, inside your subarachnoid. It will lead to ICP if you have increased proteins. So increased protein indicates infection as well. Increased glucose also results in infection. So let's read why chlorine, magnesium, right? So blood CSF levels. Chlorine that is found in CSF more than plasma is because chlorine is needed to balance the Na, the positive ion, as CSF also has Na. Okay, so we need chlorine negative ion to balance the positive ion, that is Na. As CSF is low in protein, so protein are negatively charged, right? Protein are negatively charged, so we need chlorine to neutralize Na. So this is the reason we have chlorine in CSF. Another reason we have Mg is that Mg can move freely than CO2, right? And it bounds less to protein. So as CSF is low in protein, free Mg, right, is available to block MDMA receptors. So NMDA receptors are present at neural cells, and these cells are usually antagonized, usually stopped by these Mg, right? Once we remove this Mg, the calcium can bind and then it can releases the neurotransmitter or whatever the pathway is. So Mg is very important to stop these NMDA receptors from, it's a natural physiology. If we don't have Mg, it means it will result to increased activity of NMDA receptors that can lead to a lot of things. Okay, so to stop NMDA from freely regulating, we need Mg. So that's why Mg and Cl. Another thing is that glucose needs glut, right? What is glut? Glut is the receptors for intaking glucose, because glucose is a big molecule, right? So CNS constantly eats glucose, right? So CNS is, what is CNS? CNS is central nervous system. So brain eats glucose all the time. So CFS is low on it. If a bacteria invades this CSF, the glucose level drops even lower. Okay, so if the levels of glucose is lower, very lower, it means something is in there, and it's leading to bacteria attack. Another thing is that CSF blood brain barrier, that is CSF blood brain, the proteins are not allowed. These are big particles. If the barrier is broken, it means we will see proteins in CSF. That is a classical representation of Guillain-Barré syndrome. Okay. By the way, Guillain-Barré is is it ascending or is it descending? You can tell me. Well, if we are attacked by botulism, the Botox toxic, well, it's a descending pathway. It's a descending paralysis. It means it starts from the head, goes inferiorly. But Guillain-Barré is opposite. It goes retrogradely. It means it goes from down to up. So that is Guillain-Barré. So if we see protein in CSF, great example of Guillain-Barré. Okay, so that was CSF and plasma circulation. Okay, let's see about applied aspect. So if there is some sort of CSF leak, what happens is that there is a marker called beta-2 transferrin. Now, this beta-2 transferrin is the characteristic of CSF. It is only present in CSF. Why the hell it's only present in CSF? Well, beta-2 transferrin, it's a protein, right? And this beta-2 transferrin is CSF specific. Why? Because it is a form of transferrin, first. Second, it's made in choroid plexus, okay? And third, it's absent in plasma because there is no work of plasma in relation with choroid plexus, okay? So that's why beta-2 transferrin is a characteristic of CSF. If we have any sort of CSF leak, we will check for beta-2 transferrin, and if it's present, it means some sort of CSF is present. Let's talk about CSF. If CSF is getting leaked from nose, we call as CSF rhinorrhea. If CSF is getting leaked from the air, we call as CSF otorrhea. And these are both CSF-led diagnostics. We can check the liquid coming out of your ears, and we check for beta-2 transferrin. And if the beta-2 transferrin is present, it means there's a leakage of CSF, okay? Another thing we can do is post-lumbar puncture, headache, right? So we do a lumbar puncture, right? And after this lumbar puncture, what happens is that we take some sample of CSF out. Once the CSF is out, what happens is that the cushioning effect of CSF is lost. What the hell is cushioning effect? Well, the concept is very simple. The concept is that why do we even need CSF? We need CSF because actually what's happening is that you have brain right here, right? And what happens is that brain is actually floating in this ocean of CSF, right? Because you get hit every day, you get punched every day, you get slapped every day, someone comes and hugs you from behind, someone can shake you up. Now we cannot leave this brain, this vital organ, on the mercy of, on the mercy of nature. We need some sort of cushion that in which the brain floats, so that brain can, move in this ocean, right? So that's why we need CSF. So if we remove these CSF, what will happen is that there are a lot of, blood vessels, there are a lot of arteries that are present in something called a subarachnoid space, and these arteries are actually floating. They are floating in the CSF, right? And CSF work is to make sure that they are not, they are not they're not damaged, they are not clotted, they are not messed up. This is the work of CSF. So if we remove a lot of CSF, what will happen is that brain will sink in some direction. It will either sink, and once it starts to sink due to less CSF, it will herniate those, vessels. It will block these vessels or block these arteries, which will result in a very painful headache. So that's why if we have intracranial pressure, increased intracranial pressure, what happens is that this CSF pressure is also, obstructing the arteries and the veins, that results in this headache. So that's why ICP leads to headache, and that's why we have headache after the CSF loss. So Cushing effect is lost, traction on the brain leads to headache. It's very simple. Okay, another thing is CBF, right? CBF. What is cerebral blood flow? What is it, cerebral blood flow? How the blood flows into the brain, right? Now, it's very simple. Let's see. General properties. What's the property? Well, the property is that the blood supply it comes from something called a circle of Willis. Well, circle of Willis is like, I can explain you in very short terms. It happens that two main arteries are coming up, right? And then they make a circle right there, like this. And from this circle, we have anterior distribution, right? And then we have posterior distribution, right? For the posterior brain. This is your brain right there, right? These are your eyes. These are your eyes, right? And then we have something called lateral distribution of this, in this circle of Willis, and we have two main arteries that is, joining them. Then from the behind we have another artery, right, coming both on the lateral side posteriorly, and they make something, this blood supply for your pons, for your brain stem, for your medulla, right? So we have four type of main arteries coming. Okay, so this whole circle is the circle of Willis. What happens is that we have this circle of Willis and it distributes blood, right? So this is the circle of Willis. I hope it's a very rough explanation. It's not a very good explanation. What happens is that it forms circle of Willis for the good blood supply. It supplies gray matter more than white matter. Why? Why does it does that? Because gray matter is the computing part of your brain. White matter is the non-computing part, the cable part, right? Once you attach some cables from your CPU to your monitor, what happens is that this cable is the white matter, this CPU is the gray matter, so blood is more needed at the CPU. Of course, it's nonsense to think otherwise. Other thing is that CBF it's good for nutrition. Blood gives us nutrition. It's very normal. This very important. Normal CBF flow is 750 ml per minute, right? So it's 14% of your cardiac output. It's very important to understand. We make around 5 liter of blood, right? And not make, we have 5 liter of blood at one instant. And what happens is that this 5 liter actually moves inside your body, and this 15% of 5 liter is around 750 ml, and 750 ml is the priority of brain. So this is very important. What about O2 consumption? So when we talk about cerebral blood flow, we are indirectly talking about brain. How much the brain uses? It uses about 750 ml. O2 consumption, how much the oxygen used by the brain. The oxygen was used by the brain is around 20% of the total body resting O2 consumption, right? So the area that is most susceptible to hypoxia is low oxygen, okay? Hypoxemia is the low oxygen in the blood. So hypoxia leads to hippocampus. Why? Hippocampus is highly metabolic, highly not metabolic. The metabolism of hippocampus is really vascular. That's what I'm trying to say. It's really vascular. It needs a lot of blood. So as soon as you stop the supply of oxygen, the hypoxia attacks the hippocampus the first, okay, and then the thalamus, and then inferior colliculus, then basal ganglia, and then other things, okay. Note that liver receives the highest percentage of cardiac output. Now it's very good, explanation why does it do it. It does it because liver has something called as dual blood supply, right? We know the portal circulation of liver is there, and then we have something called a hepatic artery, right? So it has dual blood supply, but brain has only one not the aim of saying that liver has more blood supply, it means that it has more arteries. That's it. It has two blood supply, portal and hepatic, and liver is one of the highest, one of the largest brain, that is around 1.5 kilograms, and it has something called a sinusoid. I hope you know that. So if you don't know that, sinusoid is actually responsible for the low resistance of blood flow. So the blood flow increases, flow rate increases. So due to the presence of sinusoid, and there is other thing called central hub for metabolism, because whenever you eat something messed up, whenever you eat something good or anything, it goes via liver for the checking, so that so conversion of from lipo this thing called, there are two things called lipophilic and lipophobic things, okay. So something that can travel in blood and something that cannot travel in blood, liver usually can change the property, not change the property, actually manipulate the property. What happens that liver can change the way something can travel in the blood. It can make not anything, it can make some things urine soluble. So that's why liver needs a lot of blood supply. Factors affecting CBF. One of the factors is that auto regulation, right? We cannot leave it on the mercy of heart, right? For example, you're feeling really lovely, you're feeling really excited, so blood supply increases, and then you feel, I don't know how do you feel, but I mean, we cannot just leave our brain on the mercy of heart, right? You can feel sometimes really sad and you want to kill yourself, and then what happens that, imagine if it's not auto regulation, what will happen that you will feel shit and you will die, because your heart is controlling your brain. So we need auto regulation of blood supply of these brain. So that's why it's very important for auto regulation of CBF. Another thing is that perfusion pressure, the range of perfusion pressure is just hemoglobin and then oxygen, right? Perfusion pressure is around 65 to 140 millimeter of Hg. So this must stay constant, because again we cannot leave the brain on the mercy of heart. Okay, so what is hypercarbia? Hypercarbia is that when we increase the partial pressure of CO2, right, we increase CBF, right? Hypothermia. Hypothermia is that when we feel some sort of temperature. So every 1 degree goes down, the CBF blood flow goes down by 7%. Right? So how does it happen? It happens that hypothermia leads to low partial carbon dioxide pressure, right? And this partial pressure of CO2 leads to vasoconstriction, right? Because low pressure equals the blood wants to run fast, right? Because you have low partial pressure, right? So vasoconstriction happen, which leads to this low CBF. Okay, hypothermia also can directly induce vasoconstriction, so that will also lead to CBF, low CBF. So hypothermia can also lead to low CBF. Significance is that therapeutic hypothermia can be induced in neurosurgeries, and we can start giving less. So imagine you are on a table and you're getting surgically diced, and your surgeon wants to save your brain. It's just you will be put on a low, maybe they will reduce the degree by 5 degree, and then you will have something or less 30 degree less CBF flow. So it's really nice. Why does it happen in hypothermia? Because in hypothermia the brain demand goes less, so metabolism goes less, so CBF goes less in hypothermia. Okay, let's see. So this thing is over, right? Things to remember is that 750 ml, 14% cardiac output. Liver is the highest one. Hypothalamus is the first to get damaged. CSF rhinorrhea, CSF otorrhea. We look for beta 2 transferrin. Another thing is that epidermal choroid plexus, 112 milligrams is the normal pressure, right? And the pressure here is measured in H2O. Usually pressure for respiratory system is also measured in H2O, so remember that. Let's start with blood-brain barrier. What happens in blood-brain barrier? What is it? We need a blood-brain barrier because whenever we eat something, we cannot let that thing affect our brain, right? So we need some sort of structure to protect our neurons, right? We cannot leave it on the mercy of us because we feel shitty a lot of times and we want to eat something bad and then it can influence our neurons, right? We need some sort of private party from these neurons, okay? Okay, so structure of blood-brain barrier. What happens that these blood-brain barriers, they are covered by endothelial cells, and these endothelial cells, and they have something between them is called tight junction. They're tightly packed with each other, so they have tight junction. And then these tight junctions are covered by astrocytes. Astrocytes are like, astro means stars, cytes means just cells. So stars shape glial cells, and by the way, the cancer of astrocytes is called astroglioma, something like that. I don't remember, something with astroma like that. So astro, we know that astro have something called a foot process. We call it, I think, podocytes, and these podocytes actually covers the blood vessels. Okay, so this is the blood vessels coming. Wait, let me draw it again. So this is the blood vessel coming right here, and what happens that this is one astrocyte, and these have like these, these legs, and this is like covering like this, and this is one astrocyte. It's really cool. I want to discuss this topic in detail, but I don't think I will be. I don't want to make this video very long video, so that's the thing. Movement across BBB, blood-brain barrier. So the concept is that you don't want really ionized, really big particle inside your neurons, not inside your blood, inside your brain environment. You want to keep this brain environment really private. You want to keep this, environment really clean. What happens that substances that can cross BBB are, first of all, lipids mean fat soluble substances such as steroid hormones. So steroid hormones are really important. A lot of them are synthesized from this hypothalamus to posterior and anterior pituitary, and then it goes to adrenal cortex and medullary cortex and adrenal gland. So you need this steroid hormone you need it because steroids can influence your brain health. So you need steroid hormone for the growth of your brain as well. Other thing is O2 and CO2 and nitrogen. They can cross the blood-brain barrier. So imagine you have CO2 poisoning. So we need hyperventilation so that we can throw this CO2 out, right? That's why we need gases that can cross BBB. Other thing is that nutrients we need, because brain loves glucose. Okay, brain doesn't love fatty acids. Actually, in reality, fatty acids cannot even cross the BBB. What can cross is that ketones. So in ketoacidosis means the ketones are getting made. What happens is that ketones can jump, and then it can give this nutrition to your brain. And glucose is the number one thing that your brain wants to eat all the time. So I think around 20% of the whole glucose you eat, it's right away goes to your brain. So glucose is very important. Other thing that can go to your BBB is that water, because water is essential for a lot of things. So via equiporin 4 channels, the water can jump, right? Other thing is that GLUT1 are present at the BBB. So via GLUT1, the glucose can jump. If we have less glucose levels, it means something is eating up that glucose, and probably it's some sort of meningitis or some sort of bacteria, maybe gram positive, that's eating that glucose, that's giving the less glucose levels, right? Substances that are unable to cross, it means substances that are dangerous, that can be dangerous, that can mess up you, is first of all protein hormones. Protein hormones, I told you, very big in structure, okay? Very huge. So protein hormones such as insulin, right? Another hormone, it's I think it's insulin is like 51 amino acid chain, and another hormone is called, I don't remember, a lot of protein hormones that are like 81 amino acid chain, 52 amino acid chain. So these are really big hormones. They are really big anabolic or catabolic hormones, right? So you don't want to make sure that they cross. So again, protein hormones cannot change. Ions is, again, if you these ions are radical ions, they can produce something called as bleach, and then bleach can actually destroy a lot of neurons. So you don't want these radical ions, right? Other thing is that neurotransmitter, it's really surprising because a lot of people say that, oh, dopamine, but they really don't have any clue how dopamine is released and how dopamine actually works. How dopamine actually works is that dopamine works via the anticipation pathway. So when we are like really anticipated, for example, like when you're about to kiss your crush or kiss your woman, or kiss in generally, what happens is that this anticipation time actually is the time where the most dopamine is released. And when this anticipation time is like ended, when you on that point when you kiss the woman, what happens, that a lot of dopamine is released. That's how the dopamine really works. But okay, so I just went from the main topic to the side topic. What happens that L-dopa can jump because it is smaller, it has something that can cross the BBB, but dopamine cannot. I will tell you why it is like that. It's a really different topic. So L-dopa can cross, dopamine cannot cross. Okay, so in a disease where there is dopamine deficiency, we need to give not dopamine but L-dopa. It's an analog of dopamine. Aspide expect is that in some disease called Cason disease, the levels of N2, right, nitrogen increases, right, and it's really bad for your brain because its nitrogen can be very toxic to your neurons. Another thing is that neuromyelitis optica. It's a cool name. What happens is that when happens is that there are antibodies, right? Antibodies like IgM, IgG, IgE. These antibodies are produced against your aquaporins. So if these aquaporins are messed up, water cannot jump, and once water cannot jump, it will happen that a lot of basic regulatory mechanism will not work. And one of the regulatory mechanism is that myelination. And what happens that myelination will be affected. Once the myelination affected, the basically the fat layer on the neurons is messed up. What will happen that a lot of abnormal electrical signaling can happen. So demyelination, L-dopa. So I hope you understand this. Neuromyelitic optica, Cason disease. Another thing, L-dopa can cross. We can use it in disease of Parkinson's, because we know at Parkinson's, in the pathway called it's in the pathway called not reticula, in parts. So there's a pathway called parts compacta, and in this pathway, basically dopamine is released, right? Dopamine is inhibitory, and once this dopamine is stopped, what will happen that you will have abnormal chorea, abnormal movement, because dopamine is not happening. There is no inhibition. So we can give L-dopa to give some inhibition to the motor neurons, and this is the treatment for Parkinson's. Okay, gatekeeper of BBB. Gatekeeper means something that's keeping the blood-brain barrier. So there is a guard called P-glycoprotein. It's a glycoprotein. It means it's a glucose plus some protein. It's a guard. It actually makes sure that things are not jumping around the blood-brain barrier. There's a BBB, and what happens that it's a channel which filters drug crossing BBB. Once we don't have this, that we can. So if we don't have this, P glycoprotein, anything can jump basically. So what happens that this L-dopa actually can stop this guard, right? So P glycoprotein is blockers, right? We can give this P glycoprotein concentrate drugs in the brain, right? Used in treatment of brain neoplasms. Brain neoplasms means new, plasma mean growth, plasms mean growth. So cancers of brain, we can treat it via blocking P glycoprotein. Okay, circumventricular organs. So what happens is that blood-brain barriers are actually constantly checking the composition of your blood. What are you carrying in your blood? Is there anything toxic in your blood? Why is it important? Because if you eat something really toxic, you want to puke that out. And how the brain does it is like it's constantly checking, via these seven places. These blood-brain barriers, stopped there. It's blood. It's open, so it keeps it's keep checking these sample of the blood, and if it sees like something is messed up, what happens is that it right away sends the signal to your emetic organ. Emetic means just vomiting. Okay, so right away when it feels that something is not right, you feel to you feel you want to puke, and then you puke, right? That's the physiology of it. So BBB is absent at seven places, right? The mnemonic for remembering these four things are SOAP, that is subfornical organ, right? That is organ vasculosum of laminae terminalis. Other thing is area postrema. That's my favorite, area postrema. And then we have posterior pituitary. So we have anterior and posterior. Posterior, its BBB is broken right there. So allows passage of protein hormones, okay, because BBB is broken. For example, angiotensin 2 acts on, right, SFO, makes you thirsty, right? So this is the whole thing. That's why at the posterior pituitary, we know pituitary gland is one of the endocrine exocrine things, right? One of the way of endocrine physiology works is via anterior and posterior, and that's why we have hypothalamus axis, right? So that's why we need this BBB to be broken at posterior pituitary, so that protein can keep getting sampled by the brain. Other thing is called Monro-Kelly doctrine. What is Monro-Kelly doctrine? What happens that the volume of CSF, right, plus the volume of CBF, right, the blood volume, the CSF volume is always constant, right, plus volume of the brain, right? So if you increase any, it will obstruct the others. That's the whole concept. So rise in any one of these compresses the others, right? So CSF blood flow, right, less blood flow compresses the brain. Increased CSF blood flow leads to less blood flow, less CBF, and then it compresses the brain tissue. Then we can get some necrosis or some sort of stroke like symptoms. So that was the whole topic of CSF. It's really simple topic, not hard topic at all. So I hope you enjoyed this thing, because I enjoy it a lot. So have a nice day.